Hello, everyone. Welcome to our first CalMap Project Echo core series meeting. It's great to see all of you here today, at least virtually. Um, and as we're kind of rolling in, it'd be great if you can go ahead and drop into the chat your name, maybe your organization or clinic that you work for, and what county you're in. And if we can go ahead and move into the next slide. And while you're at it, in this very scientific measurement-based care way, let's rate ourselves on the rubber ducky scale today, 1 to 9. How are we doing today? And so while you guys are dropping your names in the chat, I'd like to introduce myself as well as some other members of the ECHO team. For those of you who haven't had a chance to meet me yet, my name is Joanne Jung. I am actually a general pediatrician. I did primary care in a federally qualified health center for 10 years here in Oakland, where I live. And I work for UCSF, and I serve as the Senior Associate Director for CalMap. I also want to introduce you some other members of our hub team here. Dr. Laura Schumacher is a child and adolescent psychiatrist. She'll actually be speaking with us a little bit later today on our topic. And she helps to organize these Project Echo sessions for all of us. And so it's Lauren Schumacher. It's a little virtual wave there. We also have with us May Lum, who is the program manager for CalMap and helps us to just keep us organized behind the scenes, as well as Rita, and I'm not going to do justice to your last name, who is our program coordinator and really keeps all the details and the logistics straight for all of our educational training programs. I also want to introduce to you Dr. Anna Swan, who is a psychologist and who was here at UCSF for many years and is now off in the private sector, but is back today to help give the talk on anxiety. So for those of you who are just coming in, go ahead and just keep dropping into the chat your name, what organization you work or clinic that you work for, and where you are on the rubber ducky scale. And I realized I have not yet shared where I am on the rubber ducky scale, and I think I might be a 4 today. I had a late night the other night. I'm still feeling the effects of it. And yesterday was a long double booked clinic day. So I was up a little bit later than I wanted to be charting yesterday. So I'm feeling the effect of that. And I think many of us might be feeling that as well. Well, good to see you. Let's go ahead and move on to the next slide. I took a quick look at the registration form, so I know that the majority of us coming in today from all across California, most of us haven't actually participated in one of our echoes before, although a few of us have. And so I just wanted to let you know a little bit about what Project Echo is. And so what it is we do a little bit of a lecture, okay, just as we're going to be doing today on anxiety. But the second half of our hour, we're really talking about a case together. And this is not like a little wrapped up pretty teaching case with a bow on it. This is a case that we're carrying and have lots of questions about. And this is a chance to talk about it in a supportive group community with our colleagues, other pediatric primary care providers from all across the state, as well as with our subject matter experts, psychologists, psychiatrists. And this is an all teach, all learn situation. We all have our experience and our knowledge to bring into this, and we have a lot to learn from each other. So the case discussion is a really important part of this. And that should take us through the hour. But for those of you who can stay for a little bit longer, we often found that we weren't quite ready to end our conversation when 1 o'clock came around. So for those of you who have the time, we have an optional extended discussion time that runs another 10-15 minutes afterwards. It could be about the case, it could be about other things, other questions related, unrelated to the topic. But it's just a way of just continuing the discussion for those of us who are able. And so this is the general format that we'll be following each week, going from here on out and going on into the next slide. So these are our Project Echo principles. I already talked about all teach, all learn, and this is the beauty of Echo. We are a peer learning community. This is going to be a safe place. A pediatrician, a very experienced and well-respected pediatrician that I know from San Francisco, came into this, our first Echo, saying, we all feel like interns again. And I think this is a common feeling for many of us. And there is no such thing as a dumb question. We are all in this to learn and to help teach. We are sharing best practices um, across our various disciplines in an effort to reduce disparities, because we know that mental health care access is really limited for our children and youth. And so in this way, we're spreading our expertise and sharing our expertise within this learning community to help reduce some of these disparities. And I love this quote, and this quote comes from the founder of Project Echo in New Mexico. And he said, what makes Echo work isn't just knowledge, but love, kindness, respect, and sharing. And this is the kind of community that we really hope to be able to be building together over these next 6 months. Um, as we meet every second Wednesday at this noon hour. And let's talk a little bit about the nuts and bolts. Going into the next slide. Okay. Oh, I guess the nuts and bolts, did that get, was that missing? Okay, here they are. Okay. We are meeting 6 times over the next 6 months. And this is what we call our core series. We're talking about anxiety, depression, ADHD, using SSRIs, triaging suicidal ideation and managing and helping to prevent suicide, and then talking about autism spectrum disorders. Feel free to drop in when you can, but for those of you who can show up all 6 times, we have a core badge to give you that can sync into your LinkedIn and be added to your CV to help demonstrate your commitment to learning about pediatric mental health. We are a virtual brown bag kind of community coming from across the state of California. We are recording the didactic portion, but especially during the case discussion, we are turning that virtual camera off, but we invite you to turn your cameras on so that we can actually see each other face to face as we're having our conversation. And in the spirit of all teach, all learn, let me know if you've got a case that you want to share related to the topic of the day. And so our next discussion, I think will actually be depression. So if you've got a depression case that you want to share, let me know by the end of the day. And just a quick reminder, in addition to offering this education, we do have our consult line. If you want more individualized guidance on how to help your patients, we just dropped this number here that you can call directly, this 800 number, or request a consult online on our website. Okay, I think those are the kind of like the nuts and bolts. And with that, I want to go ahead and move us on to a more complete introduction for our speakers. So Dr. Anna Swan is a clinical psychologist who is board certified in child psychology, and she has had 10 years of clinical experience practicing as a child clinical psychologist with children, teens, and young adults, specializing in anxiety and related concerns. And she's worked in academic medical settings as well as embedded in primary care, in university settings, as well as outpatient clinic settings, providing clinical care supervision and training. We also have Dr. Lauren Schumacher, who is a child and adolescent psychiatrist who specializes, of course, in caring for children and adolescents. She has particular interest in anxiety and ADHD, as well as medical education. These are the disclosures, and all relevant financial relationships have been mitigated prior to this conversation. You can see a little bit on our funding. And with that, I'll turn the virtual mic over to Dr. Anna Swan and Lauren Schumacher.
Great, thanks so much for having us. We're excited to present on anxiety. Next slide. So our learning objectives are for you to come away feeling comfortable identifying and diagnosing anxiety in primary care, being able to talk about cognitive and behavioral strategies to use in their caregivers, and also to determine when to consider medication for treating anxiety in youth. So, to get us started, what is anxiety? For anybody who saw the sequel to Inside Out, anxiety had a starring role, and it's because it's a feeling that we all get to experience. And there are three components to anxiety, as you can see on the slide. So, there's the feelings piece. Think that fight, flight, freeze response. So, if I have a test coming up, feeling a little nervous about it, 2 out of 10 on my scale, I might have some butterflies in my stomach. Then there's the thinking piece of this. So, when we're feeling nervous, our anxiety is helping us think ahead to the future, spot potential danger or threat. So, I might be thinking, there are some concepts that I'm not quite sure about. I might, not know how to answer some of the questions on this test. And then there's the behavioral piece. So when we're feeling anxious, it's sort of our body signaling there's potential threat, there's potential danger. And so usually we try to avoid or escape that situation that's making us feel anxious. So that's the action urge associated with anxiety. And with this test example, I might decide to ask the teacher for some help or do a little bit more studying. That makes my anxiety go down. I feel more prepared for the test. So that's an example of really healthy adaptive anxiety. Next slide. But as we all know, anxiety can also become a problem and it can become a bit of a false alarm. And so if we take that same test example, maybe now I'm feeling like an 8 out of 10 on my anxiety scale. And I'm not just feeling butterflies, I'm feeling nauseous. My mind is going blank. I'm thinking very all or nothing, doing a lot of jumping to conclusions. I don't know anything. I'm going to fail. I'm not going to get into the college that I want to get into. And then I'm feeling so nervous that I procrastinate. I can't bring myself to study because every time I think about that test, I feel so terrible. So I avoid it, I put it off. Or maybe I go the other direction. Maybe I over prepare. I'm so nervous about failing that I spend all night studying, or I study at the expense of other things that are also important to me, like time with friends or family. And so here, sort of the anxiety alarm is saying that I'm in a really dangerous situation when it's actually not as scary as anxiety is saying. And when we're talking about this with families, we'll often use this false alarm analogy or kind of like a broken smoke detector. So you might ask a kid or a parent, you know, when the last time that your fire alarm went off in your home, was there a fire? And almost always the answer is no. And so you can ask, well, what was going on? Somebody burnt the toast, there was a dead battery, it was a drill. And so that's what's happening with anxiety is this alarm is going off saying like danger, 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 but really it's all smoke and no fire. And so when that's happening a lot, it can cause significant problems. And so when you're wondering, you have a family in your practice, is this anxiety crossing that line from everyday to meeting criteria for an anxiety disorder? There are 4 things I like to consider, and they all start with a D to help us out. So the first one is dysfunction. And in some ways, I think this is the most important. You really want to think about, is this anxiety causing meaningful interference in the child or the family's life? Is it holding them back from what they want to do or what they need to do at school, with friends, in their family? Are they not reaching their full potential in school because they're nervous to participate? Are they having a hard time making friends because of their anxiety? Maybe the child is feeling like things are okay, but the whole family's routine is disrupted at night because of their worries. So those are all sort of ways that you can think through, is this causing a problem? The second is distress. So we all have personal experience feeling nervous. It's not a fun feeling to have. And so when that alarm is going off intensely and frequently, it can lead to a significant distress. A lot of times these families are coming in just feeling, you can sort of palpably feel, the energy in the room and how upset everybody is. The third is duration. So, how long has this been going on for? I think this is a beautifully timed echo because we're about to enter the school year, and most kids and teens and parents are feeling some nervousness around this transition point. And so, we expect there to be some elevated anxiety, that first week, maybe even first month getting back to school. But if anxiety has been persisting for months, certainly 6 months or longer, that indicates this is not going to go away on its own without intervention. And then the fourth is deviation from the developmental trajectory. And so I like to think about this in two ways. One is sort of how is this anxiety showing up compared to where the child is in development? So, we expect to see stranger danger in a toddler, but if you're seeing an elementary school or middle school student who's having that heightened fear response meeting somebody new, that indicates this is not what we would expect from this developmental stage. And the second way to think about it is just the impact of elevated anxiety on child development. And so you might think about that young kid who comes in with separation fears. They have a hard time being away from family. So they miss out on those play dates. They miss out on those opportunities to build social skills. And now it's middle school and they're feeling more social anxiety and they're having a harder time making friends because they didn't have those experiences. And then you can easily see that fast forwarding to young adulthood. Now it's time to launch, to go out, to leave the home, to get first jobs. And there are these developmental tasks that they're having a hard time doing in addition to the anxiety because they've missed out on these opportunities. Next slide. So here's some quick facts. Anxiety disorders are the most common mental health concern that youth experience. Three in 10 will meet criteria by 18. They also tend to get overlooked. Often these are the kids who might be that straight A student or they really fly under the radar. And so they don't get picked up at the same rates and referred for services that a child who's having behavioral difficulties does. At the same time, as we've talked about, their anxiety disorders do lead to meaningful interference and cause lots of problems. A lot of times families will also come in kind of wondering, maybe if we just watch and wait, like this will kind of go away on its own. One thing that we do know is once a child is meeting criteria for an anxiety disorder, they're hitting on those 4 Ds. The anxiety does not typically resolve without intervention. It tends to actually continue on into adulthood and to lead to more problems over time, things like more anxiety disorders, depression, and substance use. So we really want to be able to identify and intervene early. And so there's some good news. The National Comorbidity Survey for Adolescents reported that when youth were identified and encouraged by providers like you to seek services, they were more likely to seek services. And for the most part, that was true. No differences based on race or ethnicity, with one really notable exception. So Black youth who had low severity internalizing concerns, things like anxiety and depressive symptoms, were less likely to be identified and encouraged to use services compared to their white peers with similar levels of concerns. And what this really highlights is anxiety disorders already are less likely to be identified, and Black youth might be at particular risk of not being encouraged to seek services when they have these lower level concerns. And that's important because we know the positive benefit of successful early intervention. And that's why we're all here, because primary care is a wonderful setting to increase both the identification and treatment of anxiety disorders. Next slide. So here we have a slide that just includes lots of different anxiety disorders. The ones bolded at the top are the 3 most common: separation, generalized, and social anxiety disorder. I'm sure you see this in your office all the time. At the bottom, I have school avoidance in italics, and this is because it's not technically an anxiety disorder, but you probably hear about this in your practice as well, youth who are having a hard time attending school because of anxiety or other concerns. And then the other thing that I want to highlight is with anxiety, comorbidity is really the rule rather than the exception. And so it's incredibly common for youth to meet criteria for multiple anxiety disorders at the same time. It's kind of just a big ball of anxiety and worry, or for the way their anxiety manifests to change over development. So that classic example of a younger kid who has separation anxiety growing into a middle school student with social, growing into a teenager with more generalized worries. Next slide.
So when you're seeing a child or adolescent where you have some concerns about anxiety, standardized rating scales can be very helpful in starting to sort out the severity of the anxiety, as well as kind of which types of anxiety seem to be most prominent. So here is a list of a number of different rating scales that are available for free use, for clinical use. Probably the most common one people use is the GAD-7. That one is great for teens, and kind of when you're specifically looking at generalized anxiety. Advantages of it is it's the shortest one. The downside is it kind of only focuses on generalized anxiety and isn't as easily used for younger kids. There's some other options for kind of the elementary to middle school age. The Scared and Spence are both great options that go into more different types of anxiety. The downside is they're significantly longer, but you can have parents and children fill them out, either in the waiting room or in between visits to help save time. And it's nice because there's both a parent and self-report. So you get both the report from the patient as well as the parent. And then for those really young kids, there's the Spence preschool anxiety scale that's created kind of for the parent report for those 3 to 6 year olds. And then if depression is also on your list of concerns as well as anxiety, the RCADS screens for depression and OCD as well as other anxiety disorders. You can see more information about these on our website, and these longer ones also do have free scoring Excel sheets online to help with scoring them. Next slide. So the good news is there are effective treatments. Generally, we recommend a multimodal treatment approach for anxiety disorders, including education of parents and youth about anxiety disorders, what anxiety is, what can be helpful, consultation with schools, considering school accommodations, therapy, and medication. Next slide.
So I'm going to share a little bit about therapy, specifically cognitive behavioral therapy, which is empirically supported for treating anxiety disorders in youth. And so just like there were the 3 sort of components to anxiety that we were talking about earlier, CBT really aims to build skills at each corner of that CBT triangle. And so youth and their families are working to identify, label, sometimes even externalize the anxiety, build distress tolerance skills so that they can sort of manage and cope through those feelings. Then in terms of the thinking piece, we're working with youth to notice thinking traps, sort of that jumping to conclusions or all or nothing I was describing before, ways that their brain might sort of have them focus on negative possible outcomes that's amping up their anxiety, and then develop skills to sort of think about these situations in different ways or just have a different relationship to those anxious thoughts. And then the third piece really targets that escape or avoidance behavioral component to anxiety. And so here we work with youth and families around building those problem solving skills, how to take this big, scary fear and kind of break it down into more manageable steps. And then in green, the real key ingredient for CBT for anxiety disorders is something called exposure, gradual exposure, where we're collaboratively helping to come up with a plan and helping youth step by step face their fears in session. And then a couple of other features about CBT that separate it from some other types of therapy. It's very goal-oriented, you're learning skills, it's time limited. We always say, the goal is to put ourselves out of business. We really want youth and their families to have the tools to manage this going forward without regular sessions once they graduate. Homework is a really key component. So there's sort of something that you're learning in session, but you're also practicing it throughout the week. And for youth, it's really important to have the family and the parent involved as well, because just like the child is getting kind of pulled into this anxiety cycle, parents are often being pulled into, and so helping the whole family have the skills. Next slide. And so I just wanted to highlight again, sort of the B in cognitive behavioral therapy, the behavioral component emphasizes exposures. And the reason this is so important is because there are a lot of reasons a youth might be feeling nervous. And avoidance is really what maintains the anxiety, because when you avoid the situation, you learn that maybe it was dangerous and you miss out on the opportunity to build the skills to manage it, or to realize that maybe it wasn't as scary as anxiety was saying. And so exposure therapy really aims to sort of break through this cycle. And an analogy I often use with families is a vaccine. So this is a good metaphor to have in mind, where you're kind of getting a little dose of the virus, you're getting a dose of the anxiety is through the therapy, so that when the world throws anxiety your way, you know how to handle it. Next slide. And then very quickly, parent involvement. Parents are a key component to working with youth. And really at its core, we're helping parents to support their child to face fears rather than avoid. And there are also now some parent-only interventions that really just works with parents on how they can change their own behaviors and responses to help with their child's anxiety. And then quickly, there is an acronym that I like to use for, what parents can do to care for their child with anxiety. The C stands for being a coping model. And I can't emphasize this enough, just how helpful it is for parents to themselves model how to identify when they're feeling nervous and how to cope with that anxiety in a healthy way, because kids pick up on what they see around them. And so when they see their parents modeling those skills, then it's going to help their child sort of use those skills on their own. And also when parents are able to stay calm, it helps their kid to stay calm. The A stands for accommodate less. And this one can be kind of confusing because we usually think of accommodation as such a helpful thing. But a lot of times when parents are accommodating their child's anxiety, they're helping them avoid or escape those situations that make them nervous, which actually keeps the anxiety going long term. And so accommodating less is really helping parents be proactive and asking this question, is this accommodation supporting my child in taking a step toward the situation? So if that presentation, they're just no, 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 no. If they have the option of going first or going last, that's an accommodation that might help them be brave and give the presentation, or maybe doing it with a smaller group first, versus just helping them escape the situation entirely. So saying, oh, you can just do a paper instead, then they're not building that skill. The R is reward brave behavior. This is my favorite. So it's great for parents to be able to notice those small brave steps, maybe even have a more formal reward system for acknowledging and reinforcing brave behavior. And then the last is to empathize and normalize. So never was helpful to say, just don't worry about it, or to get like frustrated or punitive. And so sort of the mantra that I'd like parents to have is to be empathizing and encouraging. So I understand that you're feeling so nervous, and I know you can do it. And to help them understand that anxiety is normal, other people feel this way too, and that this feeling is safe and it's a temporary feeling to have. Next slide.
So then you've kind of identified that a youth has concerning anxiety. You've talked to them about behavioral treatment. When do you want to think about medication? So times to think about medication are kind of if they're in therapy and having limited improvement with therapy, or if they're trying to do therapy, but the anxiety is so significant that it's really interfering with their ability to engage in therapy or exposures. If the anxiety is especially severe, such as a GAD-7/16, you might want to think about starting kind of therapy and medication at the same time. If there's a comorbid disorder like depression that's requiring treatment, therapy is unavailable, or patient family preference. And there was a great large study, the CAMS trial done, that looked at kind of medication alone versus therapy alone versus the combination compared to placebo. And they saw all three treatment arms. So the medication alone, therapy alone, and the combination had significant improvements in anxiety compared to placebo. So those are all reasonable first-line treatments. And that combination treatment of medication and therapy together had significant improvements compared to those separate ones. So that's kind of our most powerful treatment for anxiety. Next slide. In terms of medications, SSRIs, particularly sertraline, fluoxetine, and escitalopram, are our first-line treatments for anxiety. And here's information about the starting doses. And generally, you would choose one of them to start with, optimize, try to increase the dose over time as they're tolerating it. If there are issues with lack of benefit at a high dose or side effects, then you switch to a second SSRI as the second line treatment. Sertraline is the one that was used in the CAMS trial. We commonly go to it for anxiety. That one's kind of tends to be in the middle in terms of how activating it is. Fluoxetine tends to be the most activating, so can be good, especially if there's a combination of anxiety and depression, where there's maybe some of that more low energy, low motivation. Sometimes when it's a youth that it's almost all anxiety and they're kind of already pretty wound up, that can be less helpful. It also has the longest half-life, so it can be a good option in teens where maybe they're having issues taking it consistently every day. And escitalopram is another good option. It has the fewest drug-drug interactions, which can be an advantage, tends to be well tolerated. And for all of them, there's a number needed to treat of around 3. And next slide. And then there's a lot of great resources out there. So here's a number of books, both for kids and parents, to work on some of these behavioral strategies for anxiety while they're kind of either, if it's maybe they're not quite meeting criteria for a disorder, there's just some concerning anxiety. This is something they can work on those skills on their own, or something they can work on while waiting to get into therapy. There's also some great apps like Grit X and Mindshift that work on anxiety, and Project Empower, which Joanne also put in the chat, has a 1-hour free session for parents about how to help their kids with anxiety. And you can go to our website for more information about resources.
Fantastic. Thank you so much. Some questions have come up, and I just wanted to just give a minute to address. And it specifically had to do with Lexapro. And if someone's doing well on Lexapro 5, can they go up to 10 on days where they anticipate high potential for anxiety, like with known triggers? And I'll direct this to you, Lauren.
Yeah, it's a really interesting question. We mostly don't, I think mostly we recommend having a consistent dose. So I think I would find out how often that those kind of higher anxiety events are happening. If it's something that it's happening kind of once a week or more, then I might consider increasing the dose a little bit, and just having them consistently take 10. If it's something where it's a pretty rare occasion, it seems like 5's really good, but then maybe, once every couple of months, there's something in particular that's more higher anxiety, really stress the behavioral strategies, kind of thinking about a cope ahead plan. The one exception, we do sometimes use intermittently increased dosing of SSRIs if there's somebody who has baseline anxiety and depression, but then also has like premenstrual dysphoric disorder. That will sometimes, for that kind of specific week, premenstrual week, they'll sometimes have kind of an increased dose for that. But I think in that situation, it's hard because the SSRIs, it tends to take time for them to take full effect. So, I don't think they would see the benefit of the 10, if they're the day before they're taking 10 instead of 5, they're not going to see that benefit. So I think, yeah.
We are going to have a separate session specifically talking about SSRIs and all things SSRIs. And so be on the lookout for that. And I'll just in the interest of time, I'll defer the question on SSRI side effects to review for that particular session. So stay tuned.